My name is Ike Flock. I'm the co-director of emergency ultrasound at the University of Florida. Today we're going to be learning how to assess the right ventricle for dysfunction. The best view for right ventricular assessment is the apical four-chamber view. Once an adequate apical four-chamber view is obtained, we compare right and left ventricular size and function. You can see that the tricuspid valve inserts a little bit higher than the mitral valve, and this is one feature that differentiates the right ventricle from the left ventricle. Right ventricular to left ventricular size ratio should be 0.6 to 1. If the RV to LV ratio is above 1, so if the right ventricle is larger than the left ventricle, that is certainly indicative of elevated right-sided pressures, as you may observe with pulmonary embolism or pulmonary hypertension. Other than right ventricular size, the other thing we want to assess is septal motion. During diastole, the septum should be relaxing towards the right ventricle, the lower pressure system. You can tell when the heart is in diastole based on tricuspid and mitral valve opening. So again, when we enter diastole, i.e. when the valves open, the septum should be shifting towards the right. If right-sided pressures are indicated, such as again with pulmonary embolism, we can see what's called paradoxical septal wall motion with bowing of the septum towards the left ventricle. This can also be assessed in a left ventricle short axis view at the level of the papillary muscles. Here again we see left ventricle and right ventricle as well as papillary muscles. In diastole, i.e. when the left ventricle dilates and relaxes, the septum bows out towards the low pressure right ventricular system. With pulmonary embolism or other conditions that elevate right ventricular pressures, we can observe what's called a D sign, where in diastole the septum takes on a characteristic D shape because it's pushed towards the left ventricle.